אבל אתה לא מופיע לי עכשיו. Please wait for the host. בטוח זה אני? כן, היה לי מיטינג, זה אני?
אתה רואה אותי
לא, עוד לא. בכוונה פתחתי.
זה לא אותו אחד.
אבל זה בדיוק הכותרת. הנה, פה כתוב, זה המספר הזה?
כן, אני יודע.
הנה, זה עכשיו התחבר. מרחק רסה. אוקיי, more co-host. יאללה. נראה שנסגור את זה לגמרי. לא, אם נסגור לגמרי, זה שתהיה הוסט, נכון?
מה זה?
נעשה אותך הוסט, עדיף, כי אז אני יכול לסגור לגמרי. דווקא אותך לא רואים?
תשים אצלך.
טוב.
תשים אצלך, אני אשתיק את שלי.
Can you see us there? Yeah.
Hi, Gary. Hi, Heather. Can you hear us?
This is Oisin here. Hey,
How are you getting on?
how are you?
Hi, Oisin.
How you doing?
רגע, אז אני אזיז שירות לך גם. טוב, אם אתה צריך לשבת פה, זה הכי טוב.
Can you guys hear us well?
Yeah, perfect. Yeah, no problem.
That's great. Okay, so now we have a small introduction. This is Ido. It's his fault we're studying the bone marrow and alpha 1.
That's right.
Yeah.
So,
and I'm Louis.
What I think, if you don't mind, Oisin can maybe just run through a bit of the data he has, and then we can discuss things. Is that okay?
Yeah.
I just share the screen here. Perfect.
All right. Is that?
Yeah. Okay.
It's already exciting, I have to say.
Can you see the screen there? All right.
Yeah.
Perfect. Okay.
Looks perfect.
Okay. So just going to do a quick introduction. So alpha-1 antitrypsin is a 52 kilodalton glycoprotein synthesized predominantly in the liver. It's best known as a serine protease inhibitor, but recently we've also shown that it possesses significant anti-inflammatory properties impacting on IL-8, LTB4, and TNF-alpha neutrophil signaling. We've also shown in previous publications that altered alpha-1 glycosylation, particularly increased M0, M1 bands, which we'll show you later on, now as electrofocusing gels, is indicative of increased silation, resulting in increased binding of interleukin-8 and NAP2, thereby regulating chemotaxis. Now, with the patient cohort that we received, the overall patient population was 52, 26 from Rambam Hospital, 10 from Hadassah, 13 from Ichilov, and 3 from Soroka. Now, with regards the alpha-1 glycosylation in the patient cohort, the alpha-1, so the alpha-1 protein phenotyping glycosylation analysis in the graft versus host disease patients was verified by immunofixation by serum glycoforms via isoelectric-focusing gel electrophoresis. We use a CB hydrasis machine in order to carry this out. Out of the 52 patients sampled, 41 had increased glycosylation. When I'm talking about that, I'm talking about in particular M1, M0 bands. 4 cases of which were on the day of transplant, 5 7 days post-transplant, 7 cases 14 days post-transplant, and just a once-off 28 days post-transplant. However, 24 patients already had altered glycosylation prior to getting the transplant, having M1 bands, and 5 of these 24 experienced further glycosylation post-transplant. So they went from having M1 bands going up higher to M1, M0 bands. I'm going to show you a couple of examples of what I'm talking about here now with a few of our isoelectric focusing gels. So the next slide will show you the patients that didn't seem to mount an altered glycosylation profile before or post-transplant. So you can see here very clearly your -7 day of transplant and 7, 14, and 28 days after transplant. And we can see here that it's fairly steady all the way across. Highest level is M2, lowest level is M8, which is totally in keeping with the MM phenotype. Now, we can see here in the following slide, in the patients that have an altered glycosylation profile throughout their time here, regardless of transplant, they're M1 throughout. And we can see here just very clearly that extra band above the M2, as we saw on the previous slide. And here we're starting to see where people are having increased glycosylation post-transplant. I can very clearly see here that these patients have a very well-defined M0 band, which gradually resolves going to day 14, day 28. Now, what we also experienced in approximately 3 patients out of this cohort was a transient change in glycoform profile right after transplant. But as I said here, which I've just shown in this particular slide, you can see in this patient that he has sort of a, from 7 days prior to getting the transplant, he has M1 bands almost all the way across, which then decrease at day 28. But if you can also look down further past the M8 band, you can see after the on the day of transplant, he's starting to develop a band that would be somewhat similar to an MS kind of phenotype. But in reality, this is just part of the acute phase reaction, and it disappears fairly quickly on. It's transient. So it wouldn't...
Oops, sorry. Can I ask, in the meanwhile, when you show a patient, is there the number or the code that we can?
Oh yes, we have all the stuff.
Okay.
We're
going crazy thinking, who's this one?
Well, you know, so this is actually quite interesting. So not all the abnormal glycoforms were transient. We found some permanent abnormal phenotypes, which we further investigated with genotyping. So we used paired allele genotyping using a light cycler PCR and with a series of known mutations in our lab. So we have a large array of different mutations in the lab, which we compare with. So just to give you an example of what that looks like, basically this is actually one of the patients. That's just an MZ compared to
an MZ. How is that possible?
Well, we did a full genotyping of all your patients. We actually found quite a few genetic abnormalities in some of them. So now, so the majority of the patients, you know, had normal phenotypes as seen in the IF gels, but a small number again were also still deficient in alpha-1, as measured by immunoturbidic assay, which also leaves the possibility of.
We have the levels actually. It's interesting to cross data.
Yeah, absolutely. Which leaves the possibility of an M null variant in the sample cohort. But just I'll go through all the particular abnormalities that we picked up and which we followed up on with genotyping. So out of the 52 patients, 44 appear to have an MM phenotype. However, 4 of those would have had what we would define as deficient alpha-1 level. Now, were they severely deficient? Only one really stood out as severely deficient at 0.85 grams per liter. But still, there's probably something that should probably look into. The other abnormalities that we saw were 2 MSs, 1 MZ, and 1 MI, which is an exceptionally rare mutation. Just to give you an example of how rare it is, I'll just show you the comparison to the Irish database. And we only have 141 MIs picked up in Ireland. Now that might be because usually their levels don't drop below 1, which is kind of the cutoff we use to pick up these people with alpha-1 antitrypsin deficiency. So there's probably a lot more out there, but still it's considerably smaller than, as you can see here, the MZ cohort, which is at around 3,982 as of this year. So, you know, I don't know how blinded you are to the side of the patients, or you know, we're blind to the patients, but you know, obviously with an MZ patient, if there's a way to let them know they have this mutation, is probably important in case they smoke or drink. As you can see here, I just have a quick slide of the mutations and the disease association as well. So in conclusion, overall, there's increased glycosylation in the patient population, but a uniform pattern of glycosylation was not observed. And the presence of several alpha-1 mutations may have an impact on the clinical course of patients, but as we are blind to their outcomes, we can't confirm this, obviously. I have all the details of all the patient identifiers for those who had an abnormal phenotype. I can send them on to you straight away.
And also the abnormal responses as well.
Yes, exactly, yeah.
That's amazing. Just so you know, we have 41.
Yeah,
Based
49.
Sorry, 49
But here we're talking about 41 that's being essayed.
51.
We actually recruited I think about 53 patients. I gave you also samples of patients who actually died before day 28.
Really?
That's about 4 of them. So we can cross match and see if their outcome fits the very interesting genotypes that you found.
Yeah.
Actually, this is mind-blowing because I had no idea that we might find, you know, patients who are deficient of alpha-1 antitrypsin here in Israel, because it's super, super rare.
We have like 50 patients in Israel, 50 or 60.
And that's obviously it's a small patient number, but it's a high amount of mutations in that.
Yeah.
Cohort.
I wonder if it goes with the susceptibility to the original leukemia or something.
Yeah,
possibly.
It could, you know.
Possibly. I was going to say the only thing that we couldn't really look into was obviously with the M null mutation. There's so many variations for the null variation. Using allele paired genotyping, it wouldn't have been realistic, and unfortunately, we would need a better quality sample. We need a whole blood sample in order to do proper full sequencing genotyping on it. You know.
Yeah.
Sorry. So you know, if there's any way you guys could get those people come back in to give a whole blood sample, you know.
Well, you mean you need the DNA for some cases?
Yeah, exactly. Like we could.
Would we do? You know, we would do gene sequencing to find for the nose. We'd do that, you know.
Yeah.
If the patient is still alive, I may be able to, you know, to ask for another sample once he gets to the, you know, for like a checkup or something like that.
Yeah.
I might have, it depends on the specific patient. Some patients actually took whole blood and froze it, you know, like for subsequent analysis. So even that might be available now. But if it's not, and if the patient's still alive, we may be able to arrange it and run a better sequencing.
Sure. Like I have all the patient identifiers to hand anyway. I'll just send you an email straight after this.
Do you want to try? Do you want to try to kind of look at those extreme cases?
Exactly. Yeah. Exactly. And I think also that in some of them, you can see the pattern starting to emerge after the transplant, whereas in some of them, it seems to be there beforehand. And then maybe the people are very sick beforehand or whatever, you know. Because we have found that in COVID-19 infection, we see a lot of M0, M1, alpha 1.
Interesting. Well, actually, if you notice the day 0, what you when you spoke, you said it's the transplant day. It's basically pre-transplant, so it's post-conditioning.
Yeah,
so the actual conditioning causes damage, and that's part of that's a strong part of the whole paper.
The other thing to think about here is we have shown is that a lot of this glycosylation is mediated through IL-6, interleukin 6. And we've shown that interleukin 6 upregulates some of these cell transferases. So it may be no harm looking at IL-6 in your cohort as well, you know.
Yes. We only have for day 28, and it's inside the whole blood assay, so it's not correlative, you know, to the levels of IL-6. It's kind of like let's say non-stimulated samples rather than complete serum levels.
But we
still have serum, but not
serum. All you need serum. All you need serum. I'd measure. What I would do is, would we have shown? Sorry, and we haven't published this yet. Ocean's put in a paper to a journal, and basically what we've shown is that if you add IL-6 to liver cells, it takes about 24 hours for the alpha-1 to be produced. but and it's glycosylated accordingly, you know. So I think you might find that you might show that IL-6 is up maybe 24 hours beforehand, and then you start seeing this pattern, or you might find it's already up, and that's why you're seeing the pattern, you know.
Yeah. Well,
So would you consider the higher levels of the M1 and M0 to be of liver damage or IL-6
no, I think
presence?
the exact opposite, actually. I think it shows the liver's working to an extent, that the liver's actually able to glycosylate normally, you know. Now, what it also means is that the liver's under a bit of stress, because the IL-6 is going to be up, CRP will be up, you know, all the other things will be up because IL-6 drives all these other things. And the other thing to bear in mind is that this means, yeah, I think this means essentially that IL-6 is working through its classic pathway here. That's what's happening here.
Yeah.
And obviously IL-6 can work through alternative pathways as well, but this is classic IL-6 signaling, you know, through an IL-6 receptor, I think, on the liver.
So
Makes
you would
sense.
consider it a physiological response to the transplant procedure,
exactly,
right?
Yeah.
Okay,
Yeah,
so
I think,
yeah.
I think
So
you're
we
right.
have to expose some of the results that we have because
Yeah.
we've measured C-reactive protein, you know, in comparison to AAT. And then what we did is we tried to run them in parallel to see the dynamics of CRP compared to alpha-1.
Okay. And did they?
Yes, yes.
Yeah, that fits perfectly.
We did some.
Yeah, because we
So
did similar
let's
things in
share
COVID,
screen.
you know.
Yeah.
And what we showed was that IL-6 is, and that's another good reason not to use toxilizumab in these circumstances.
Absolutely. Yeah.
Mhm.
You want to shut that off, you know?
Yeah, but anyway, you see,
Ah.
You tested that in that paper, יש לנו tag, אני לא זוכר, במאמר ההוא של ציטוטוקסיסיטי.
Yeah, we have IL-6. Well, we've
לא,
tried to.
תקטקולימוס.
Yeah, I tried to measure IL-6 impact on hepatocytes, urine hepatocytes, and also HepG2, you know, the cell line.
Yeah.
And we've tried to stimulate the cells with the lipopolysaccharides and IL-1 beta. And then we've measured IL-6. So the response in IL-6 was relatively prominent because if there is induction, you know, of inflammation, IL-6 will rise from the hepatocytes themselves. But the important thing was that the response of IL-6 was rather mellow. I'm talking quantity-wise, not really.
Yeah,
you know.
I'm not surprised though. I'd say the major source of IL-6, from our point of view, from the lung, is probably macrophages and cells like that. You know.
Yeah.
I would think, you know.
Yeah, it's a good point. Against working with the cell line or any cell culture.
Yeah.
Yeah, it's hard to argue with a whole mouse or a whole human.
Yeah, yeah.
So I'm having Ido share his screen. You may have to.
We'll stop our share here.
We'll stop our
No,
sharing.
it's okay. We can multiple share, but
Yeah, perfect.
yeah,
You see it?
it's coming up.
Oh, good man. That's great. Oh, that's perfect. Oh yeah, this is interesting.
לאט לאט.
Yeah.
What is CRP? Yeah.
Okay,
Yeah,
so
it's
can you
coming.
guys see this?
Yeah, we can.
Yeah, this is 1 out of 4 figures for now. נכון?
Okay, so the first thing we've done, I may have sent you some of it, but this is after, you know, a very, very meticulously done analysis. So what you see is the entire cohort's AAT levels. Then we have the C-reactive protein, and we have the anti-protease-free inhibition or
Very good.
anti-PR3 activity.
Yeah.
Now this is the entire cohort. So this is 49 patients because we've taken out the 4 patients that have actually deceased, you know, before day 28. We call them as failure of engraftment or very early infection or sepsis after the transplantation. So that is considered a transplantation procedure failure and not really non-relapse mortality such as GVHD or late infection. And the very interesting thing that we've observed here is that the dynamics of AAT are kind of behind C-reactive protein. And
Yeah,
if you know,
that fits perfectly because what we've shown is IL-6 comes first, and it takes about 24, 48 hours
Yeah.
for alpha-1
Yeah.
to go up, and you're
Right.
seeing a similar thing here.
Exactly. You
and
mean CRP might be like a twin brother for IL-6?
Yeah.
For discussion
IL-6 certainly
purposes.
drives it up, you know, and it may be a bit
Yeah.
quicker than alpha-1.
Yeah.
and the resolution is also much quicker. It comes first like a week ahead. You can actually see that it drops down to normal levels by day 28, while alpha 1 remains high in all patients.
Yeah. Did you measure albumin at all?
Albumin?
Albumin, no.
It may be something to think about. What we found in the COVID sample was when the alpha 1 went up, the albumin went down.
Yeah, it's interesting. Or even just liver functions. I mean, did we?
Yeah, I think the
did
liver has to
have
make a
it?
choice, you know. The liver makes a choice. I'm going to make alpha 1 or I'm going to make albumin, and it takes alpha 1 powder. Yeah.
And complement factors. Go on. There's a lot.
Yeah, exactly. Yeah.
Everything the liver makes.
We can
Yeah.
actually see whether
Yeah.
they have or
But
So
not.
we're
we
thinking
found
maybe
very
there's a.
interesting- We found a very interesting inverse response ratio between alpha 1 and albumin in COVID.
Okay.
Almost the inverse to
In the which cohort? In this one? Ah, you mean if?
in
COVID,
the
COVID, yeah,
COVID,
COVID.
almost the absolute inverse.
Yeah. So Ido is mentioning that we may find some, at least the hospital test for liver function. Maybe we have them in the files of the actual patients that we can recover liver function.
Would you say that we need to observe all of the time points, or would you rather to check just specific ones, depending on your results?
I would say like from our results, we did every single time point, comparing it to alpha 1 to albumin, but I know from first-hand experience how tedious that's going to be. You know, how long that's going to be for you.
But I think you have a good story though.
Yeah.
The story is quite interesting. The alpha 1 levels go up, CRP goes up, the glycosylation of alpha 1 changes. It's driven a lot by IL-6, I would think. You know, it's a good story that, you know.
Well, yeah, but now you see the twist, because some of them got acute GVHD and some of them were free of GVHD.
So does it tell you who get which? You know, which is is it a bad sign, or is it just a sign of inflammation? You know.
Yeah. So you'll have to listen to Ido again.
So for the next thing we've done, we've tried to dichotomize the groups to, acute GVHD, eventually acute GVHD versus GVHD free. So you can actually see that there was, I wouldn't say there was a significant difference in the AAT quantities or the levels in the GVHD group, but you can see that you can say that there is a first sign of difference on day 0, meaning after the myeloablation.
Yeah.
I mean, after patients are actually prepared for the transplantation day, and some of them are in a specific damage status, while others are in a lesser, or let's say more fortunate status. And you can see that both of them rise in AT levels because, as you said, IL-6 would be there. I mean,
But look at CRP; it doesn't do this.
And CRP does not rise.
No, it does not,
with
exactly.
therapy.
Yeah.
So,
That's interesting.
but it does react much faster, peaking by day 7 and still remaining high within, the acute GVHD group. And then it just drops down to almost normal levels in both groups.
Yeah.
But AAT remains higher, and that was statistically significant on day 28.
Yeah.
And
From the, if you drop or from.
yeah, from the drop.
Can I ask you, fellas, is there something other than IL-6 that's driving the alpha 1 in the GVD group?
Maybe oxygen deprivation.
See, what you could do is what we did with our COVID group was we got serum from the COVIDs and put that on cells, you know, and then we inhibited that with tocilizumab, and we knocked out the IL-6 response. But I'm just wondering, could there be something else driving up the alpha 1 apart from IL-6 here? Because IL-6 and CRP sort of correlate; they should anyway. And for a while, alpha 1 and CRP correlate here, and then suddenly it changes quite dramatically, doesn't it?
And the dynamics, yeah.
Yeah, yes, I'm saying, yeah.
Yeah, so there's like we have two. This is like a gift that keeps giving. So the fact that the myeloablation by itself is an issue. I mean, you could have 5 postdocs just discussing that, because it's a cytotoxic protocol to destroy the immune system.
Yeah.
And all the cells suffer, and you have alpha 1 rising, but not CRP.
Yeah.
Maybe the liver isn't able to.
Yeah, that's where the albumin comes in, I think, you know.
Yeah.
Or what we think better is that the response is insufficient, and that's where I'm heading with with my story. So I'll just keep on going. So we did not see any big or significant difference in the total serum anti-protease free activity, which meaning both of the groups, had higher levels of, higher inactivity or inactivation of PR3. But when we tried to conclude AAT levels and C-reactive protein levels within, we came to a conclusion that patients who, and this is a really, it's pretty
I see what you're doing,
obnoxious graph, but
I see it, yeah.
But it's important because it shows that some of the patients actually have higher levels of CRP, lower levels of alpha-1, or higher levels of alpha-1, but let's say fairly dysfunctional anti-PR3 activity. That's why I was so interested in the glycosylation of the alpha-1, because I think that it may interfere with AAT's presumable activity of inhibiting PR3. So we've made, we created a new value which is incorporated with PR3, alpha-1, and CRP. We just divided, the inhibition by all of them to reach some kind of a specific PR3 activity to alpha-1, which is corrected by the inflammatory status of CRP. So to see exactly how alpha-1 is supposed to work or to exert its anti-inflammatory.
So do you think the alpha-1 is less active in people with GVD?
Exactly.
Yeah.
And
It kind of failed. Well, that's why we need the combination. It's yeah. Go ahead. I'm listening.
Sorry, no, just because we looked at the same thing in our COVID samples, and we did Western analysis of the alpha-1 in serum, and it was nice and clean with no complexes, and it wasn't cleaved. So you wonder, is it been oxidized or whatever,
Wow.
So you would say it might be oxidized?
I don't know.
No, but the concept you're saying, if it's not functioning, but because it's already preoccupied with an enzyme, it should have shown in a Western blot twice the size. Yeah.
So that's what we did. We did Westerns, and it showed no cleavage, no complexes. It was lovely clean. Now, when we went into the lung, it was a different story. I can tell you that. It was chewed up in bits. As it was.
Maybe it was the freezing that I sent you. It took days.
But the focus here is on PR3. I'm now thinking maybe there's a compartment issue. So I mean, the suspicion came from the fact that maybe in the bone marrow, PR3 has that role in the maturation towards violent or non-violent recruitment. But in like neutrophils, we'll use PR3 just for everyday invasion. So maybe alpha-1 glycosylations can sometimes differentiate the how do you call it, the position, like where alpha-1 reaches.
No, I think that's a really interesting point. And we're coming around that way of thinking ourselves in COVID, because just to briefly to tell you about our paper, Ushin's paper, what he had shown was that the alpha-1 levels in COVID infection shoots up. It's about twice normal. It's M0, M1. It's able to bind neutrophil elastase. It's not complexed. It's not cleaved in the serum.
At what time point?
This is throughout for 2 weeks in ICU. And then what we found was we got access to lungs of people who died with COVID, and there's lots of alpha-1 in the alveoli. But when we do tracheal aspirates of patients with COVID, there's lots of neutrophil elastase there, and it's been chewed up by neutrophil elastase. The alpha-1 is. So I think this compartmentalization thing is exactly what's we're thinking about ourselves,
Yeah, because I mean, I know less than the furniture in your room on glycosylations, but I guess it has to do with like the way that it moves between tissues from the blood.
And the other thing is, we know from before, Eli, that if you have non-glycosylated alpha-1, it's passed out in the urine within hours.
Yeah, it disappears.
Yeah, it disappears. And also we know that non-glycosylated alpha-1 cannot bind IL-8.
Yeah, I remember that.
Super glycosylated can. Big time.
Yeah. I buried a master's student for that paper.
Yeah, good man.
Yeah. No, we finished, but we were measuring the binding for C3b complement D. and
C3D.
it's a 3D, and it was interesting, but for a master project, it was beyond the scope.
Yeah, yeah.
Okay, I'm going to show you some just two more figures that they might be interesting if we consider running post-hoc analysis of the patient's glycosylation, because I think it might be amazing to see how patients of different glycosylation patterns responded to the let's say functional assays of alpha-1 that I've done, which originates from the patient's serum. So give me 1 second.
Any correlation is good.
Yeah,
it
yeah,
could
yeah.
be with it's a complicated disease.
Okay, so the next thing that I've done, I hope that you were able to see it.
Yeah, sure, yeah.
אתה יכול להצניע את הטקסט, כאילו, בשביל למשוך אותו ואז יגדל.
So this over here, this is on figure 3A. You can see that the relative wound density is what I call gap wound closure, or epithelial gap wound closure of colonic cell line. It's called CACO2 BBE1. It's representative of colonic epithelium of human origin.
Ido thinks really fast. It's a culture of monolayer of epithelial cells.
Yeah.
These are cookies. And particularly epithelium from the gut, from the intestine, because you can do it with skin epithelium.
Yeah.
And Ido, with the machine, scratches,
Yeah.
and normally you'd expect it to close, and you can measure that.
Yeah, we've done those assays, yeah, yeah.
Exactly. And we look at that like the capacity of the tissue to repair.
Yeah.
So we did it at 2 specific days, and that was day +7, I mean a week after the transplantation, because that's where we see peaking in alpha-1 antitrypsin levels at first, and we thought that there might be the time of change regarding glycosylation. So we've picked up day +7 and thus +28. I mean, let's say early after transplantation and late. And we've seen that both time points were favorable of patients, let's say, capability to close the gap, let's say compared to control, which is 5% fetal bovine serum,
Yeah.
and more, let's say, more than that, when we've added alpha-1 antitrypsin, that's the serum purified alpha-1 antitrypsin that we have here in Israel, the Glacia, if you guys know
from
that.
Kamada.
Yeah, sure, yeah.
We've added just a really small amount of it. I'd say it was 10 micrograms per ml, while we've diluted the serum 100 times. So if you consider it's kind of like to double the serum concentration of alpha-1 within patient, which is not a lot.
It's like it's as if the patient has been spiked with more alpha-1
just double
at that time point.
At that time.
Yeah, exactly, yeah, yeah.
But in culture, yeah.
So what was really interesting that patients who eventually developed acute GVHD did not respond to that addition on day +7, while patients who were actually with a favorable outcome did respond to this addition of alpha-1.
That's interesting, isn't it? Why is that, do you think?
What's that?
Why do you think that happened? Why is that?
I actually think that the response of alpha-1 antitrypsin is just better because, well, if you think about it, that means that there's something in the serum that alpha-1 antitrypsin negates, which is probably proteinase 3 or other protease.
Yeah. So that's what I'm thinking. So saying it was, you could differentiate between proteinase 3 and other proteases quite simply by using alpha-1 and then use SLIPI, because SLIPI would not inhibit PR3, but it will inhibit neutrophil elastase and cathepsin G. Yeah.
Like to add something else that inhibits them?
Secretory glucoprotease inhibitor.
Okay, interesting.
It will not inhibit PR3, but it will inhibit neutrophil elastase and cathepsin G.
Discussion. It's all going to discussion, otherwise he's going to faint.
No, because I was thinking I might need to run another test.
Yeah,
I can't do that. It just is a control.
But you know, to publish, sometimes you just put it in discussion because we can't. Professor
Gary, because look, this is really amazing. Now you see when we've taken out patients who had low PR3 inhibition, you can see that it's over here.
That's really interesting.
Low. This is below the median of PR3 inhibition. This is above. So this is patients who actually had a functional PR3 inhibition. And in both time points, the patients who actually had a lower PRF3 inhibition capacity were beneficial of AD addition, which means that it depends on the functionality rather than just, you know, having more alpha-1 in your system. This is,
that's
I
absolutely
think,
true.
That's 100% right. Yeah.
I think that's absolutely correct. I'm just wondering, is there sort of a divergence between ability to inhibit PR3 and ability to inhibit other proteases? I just think they're probably be very interested in that, but that's another day's work, I suppose.
I think that you've actually published, I think not you, but I don't know if you know Bryce Korkmaz. He's a doctor from France who actually he studies PR3 quite intensively, and we know that alpha-1 is I think 2 times lesser inhibitor of PR3 compared to elastase. So
yeah.
So
there's a lot of people think PR3 is a big player in COPD as well, you know?
Yeah.
A lot of people think that. I'm not so sure. We used to do a bit of work with PR3 ourselves. And what we showed was if you get neutrophils and stimulate them, they express a lot of PR3 on their surface. And if you add an antibody to that, you get a knock-in burst. But you can prevent that by pre-treating the cells with alpha-1.
Amazing.
Interesting.
You may be seeing a vasculitis in here, you know.
Sorry?
You may be seeing a vasculitis, you know, in real life. That's what you're seeing, maybe, you know.
I actually lost a lot of patients before I think it's even before I could recruit them, because they were positioned for preemptive study, preemptive intervention with vedolizumab. I think it was vedolizumab for veno-occlusive disease, VOD.
Yeah.
Because a lot of patients suffer from VOD as a result of allogeneic hematopoietic stem cell transplantation.
That's really
so I actually, it
that
might
goes
be,
with hypoxia, actually. That could be a hypoxic liver, maybe, because of the vessels are.
okay. Really one last thing that I want to show you, because I think it might also give such a significance to the anti-PRF activity. And it's also interesting because it's pretty immunological. 1 second, we're talking about figure 4. Okay, so the last thing we've done, we've taken the same time points. Okay, we had before myeloablation, but it was too heterogeneous. So we tried to, let's say, focus on day plus 28, which means late after engraftment. So it's a whole blood assay, and also peripheral blood mononuclear cells assay for, let's say, the observation of alpha-1 antitrypsin addition on conventional dendritic cells, especially peripheral blood, you know, circulating dendritic cells. So we did not observe any difference between the acute GVHD group and the GVHD-free group in measures of circulating dendritic cells, you know, percent, because they're very scarce. They should not be circulating as much as we think they would. So it was CDC type 1 and type 2. Then we have the whole blood assay, which is quite interesting. You can see that I've tried to divide the 2 groups, and what I did over here is I measured IL-6 levels and IL-10 levels in the whole blood assay of, I think it's 35 patients. And you can see that the response to lipopolysaccharide or R848, which is a TLR 7 and 8 agonist, is that the group who actually did not develop GVHD had a better response. I mean, they were more responsive to alpha-1 addition and the stimulants themselves, meaning they're kind of like an immunosuppressed status or less responsive.
You have it, your IL-10 data here as well, right? You've interleukin 10 data as well.
And what as well?
IL-10.
IL-10, yeah. None of them turned out to be significant, but the levels are there.
Well, maybe now, if we can identify some patients, you can look at their outcome.
Exactly.
The other thing you might look at is the IL-6 IL-10 ratio, you know.
ratio.
Yeah, because
And that's per sample. That's good. Per sample.
Yeah.
So it's not like a group. It's per sample. That's good.
Yeah, yeah, per sample. Yeah.
Yeah, because this is obviously not really matched. It's just groups with
How would
IL-6
you
and groups.
Yeah, and
Exactly,
how would
yeah.
you consider a ratio? Like a ratio was lower than 1 would be favorable? Like
Well, you
IL-6
see, yeah,
divided by 10?
Anti-inflammatory. Yeah.
we have a paper on that. And it's in eBiomedicine on IL-6 IL-10 ratios in COVID infection. And you know, I mean, I suppose at its crudest, IL-10 should be an anti-inflammatory, IL-6 pro-inflammatory. And if you, the ratio would be important, I think. So we're trying to look at whether alpha-1, for example, could make you a more IL-10, less IL-6 sort of thing. You know?
Yes.
Yeah.
Whereas
Yeah.
steroids will knock out both of them.
Right.
Both of them.
Yeah. Oh, I have to show.
That's why I think that one of the conclusions that my study would bring is that maybe a combination of corticosteroids with alpha-1 would be the most beneficial, because then you completely diminish, you know, the systemic inflammatory status, but you exert more immunomodulatory effects.
Yeah,
So,
but you may have a more diffuse result whereby it knocks out everything. Whereas in alpha-1, it may be that you just knock out IL-6 but leave IL-10 alone. You know.
yeah.
Yeah.
I think you've
Like
shown that before,
uncoupling.
Eli, haven't you? Did you show it before?
We have this with dexamethasone in a separate study.
That's right. That's right.
Yeah, I might have shown you before.
You did, yeah.
Comparing combination with dexamethasone and
Correct.
alpha-1
Yeah.
in a paper on signaling, because
Yeah.
it looks like alpha-1 requires some inflammation to have some IL-10 go up, and it doesn't just do it resting. Well, like you say, dexamethasone will blunt the inflammatory triggers, and that's it for IL-10. It won't even rise. So we have that in a separate study. So, but some patients in the day 28 have steroids.
Yeah, and just
in the system. Okay, so it's not like
it was only two patients who actually suffered from very early acute GVHD, and they were treated with corticosteroids fairly early, before day 28.
But can you remind me, day 28 clinically, did they already look different?
Day 28, some of the patients are, let's say, at an imminent diagnosis of GVHD, because you can tell that they fairly look worse, but most of them do not develop on day 28 GVHD.
Yeah.
Some of them develop just a few weeks after, or even on day 28, because people consider day 28 to be successful engraftment of the transplantation. So from now on, you can decide whether or not patients suffer from acute GVHD and run all of the tests that you need to, fully determine that it's GVHD and not something, infectious or relapse or whatnot.
Yeah,
It's amazing. All this is happening under the surface of an apparently okay patient.
Yeah, because if you think about it, day 28 GVHD is almost clinically visible. So that's why we did all the landmark analysis of alpha-1 up until that point.
Yeah. So the other ratio we looked at in COVID was IL-6 alpha-1 ratio.
Okay.
Because we thought that the people who did worse had a blunted response to IL-6.
Mm-hmm.
Didn't produce as much alpha-1.
Yeah. This goes exactly with this. We're looking at this like they're underprotected.
Yeah, that's how I think it is. Yeah.
Tissue-wise, as far as tissues goes.
Yeah.
So you would say that if we divide alpha-1 by IL-6, we might actually have like another view of the poor response or insufficient response?
Yeah, you're right. I'll send you on that paper. Actually, we have that paper here. I'll send it on to you. But it's in the Blue Journal about 8 months ago. Was it?
Maybe
Yeah, whatever. But it looks at the IL-6 alpha-1 ratios.
Interesting.
I send you on both the papers, IL-6 IL-10 ratio and IL-6 alpha-1 ratio.
And the profile, right? The prognosis or severity. Wow.
I'll actually also forward on.
At some point, we can combine all these and find some like a common
Yeah, I think it will. You know.
Uniform
I think
theory.
some lovely data there. You know.
Yeah.
I only want to share one more thing because we might actually be able to conclude all of these when we talk about the glycosylation patterns.
Yeah.
The last thing I've done was to run a flow cytometry analysis of these conventional dendritic cells, and I've added alpha-1 antitrypsin. I think it was at the concentration of 0.5 milligrams per ml for each sample, and we've measured the specific activation of those dendritic cells to be able to co-stimulate or inhibit the T cells, the alloreactive T cells. So we've done it at a very analytic form of measuring one of the B7 family co-inhibitors, which is B7H4, if you guys can see it over here.
Yeah.
So we were able to see that under the under just the addition of alpha-1 antitrypsin, there was a significant increase in B7H4 expression, while CD40 remained rather the same, or actually was lowered upon inflammatory stimulation, which is, I think it's great because it shows that alpha-1 antitrypsin is not completely immunosuppressive of these cells. So this was kind of like a very good observation to, let's say, strengthen the idea of alpha-1 antitrypsin capability to increase the graft versus leukemia effect. Well, I mean, maintaining the graft versus leukemia effect while ameliorating the GVH effect, the graft versus host. So this is a really good example, and we actually have, there was a very interesting study published on mice who were deficient of B7H4, which had a really dismal, outcome for the allogeneic transplantation, meaning that B7H4 may actually be one of the key factors in regulating the GVH physiological,
it's for tolerance induction.
Yeah.
As opposed to immunosuppression, which is just.
So this was a really good example of how tolerance can be mitigated by alpha-1, specifically on these conventional dendritic cells.
Yeah.
Now, I've tried to dissect the two groups, so I actually have here, I hope you guys can see it's pretty small. So I tried to dissect the B7H4 expression on both conventional dendritic cells and on the type 2, which is called type 2, the CDC2. You can actually see that patients who eventually developed acute GVHD had a really lower response. It's not significant, it's 0.05. I would be much happier if it was significant, but you can actually see that they respond much less to alpha-1 antitrypsin. So,
and it's day 28, so that means they're already swimming in the response.
Yeah, that's also a good notion, because these patients might have be at a better state if they had higher levels of functional alpha-1 antitrypsin before reaching day 28.
Exactly. That's it.
Look at this one, because this is one of the, I'm really glad we were able to find this, inside the cohort, because what we did next is we tried to see whether or not it depends on levels of alpha-1 antitrypsin themselves or actually the functionality of it. So you can see we have above or below the median of 1.68 milligrams per ml of alpha-1. This is the median for day 28. And you can see that patients both patient groups, when they receive alpha-1 antitrypsin therapy, they actually increase their B7H4 expression.
Ex vivo.
Ex vivo, yeah, this is ex vivo. I didn't treat any of the patients. You guys know that, right? And then when we tried to dissect the two groups according to the PR3 specific inhibition, patients who actually had lower PR3 inhibition corrected to CRP had the best response to alpha-1 antitrypsin addition, which means the dynamics, rather than just higher levels of alpha-1, are the main protagonist of this whole story.
Yeah.
So it's almost like we're uncovering like another occurrence where alpha-1 is disabled in some way.
Yeah. And also it illustrates, I think, Eli, it's a timing issue, isn't it?
Yeah,
it's a timing issue.
That's why I'm saying the clinical outcome comes so relatively late, but you can see 28 days of events, completely molecular under the surface, and they're already predicting, driving force.
The point is that we've met with a group in New York where they had a trial that was published late December on treating patients who are at higher risk for poor outcome, and they could also already measure this high risk biomarker by day +7 or 14 days post transplantation. And what they did is that they tried to treat those patients with a reduced dose of alpha-1 compared to very poor steroid refractory patients who actually alpha-1 was beneficial to. And what they found was let's say, kind of discouraging, because they did not see lower levels of steroid refractory acute GVHD in the treated group. But what I believe and what I hope this trial will show, combined with the pattern glycosylation patterns, is that there might be a specific time point, or there might be a specific patient with a specific pattern that if he or she receives alpha-1 antitrypsin earlier or at that specific time, the eventual outcome would be much better, or
based on like individualized medicine formula of one.
Exactly, because if you think about it, there is a specific time on which there is no return, because once damage accumulates, adding alpha-1 to the system would do nothing. You want to prevent that. So once you have,
I think that's a very, very valid point, actually. Yeah, I think it's a very valid point, and I think that's what we're seeing in COVID as well.
Exactly. Like giving tocilizumab to patients with ICU admitted patients is just it does nothing.
No.
Wow. So do you want to look at the data set? Like if we can pick out, cherry pick those few outliers? Well, not outliers.
First of all, I'd like to see which patient, which of the, who was the exact patients with the MI mutation. I'll send it to the doctors so they can see if he's still alive and tend it.
Off the top of my head, that was a fellow from Ikolov, so it's I007.
Okay, cool.
I remember that
talk
one.
to the doctor. I'll talk to him.
Well, I remember it because it was in the beginning. We counted like 00 something.
אני יודע לבן, and he will.
אני זוכר שהמספר עלה מתישהו. הייתה סיבה there was a reason this number came up, except for James Bond.
Now, how would you conclude? How would you conclude like the glycosylation patterns? Would you like to edit? Like I'm thinking about adding it into the Cohort data frame. So how would you conclude it? Like M1, M2, different glycosylation pattern, aberrant glycosylation.
No, it's increased cellulation. That's what it is. It's increased cellulation.
Yes. So I conclude that if you have M0, M1 bands, that denotes increased cellulation, thus increased IL-8, NAP2, and then of the increased axis.
So we can divide it by time points, right? And just dichotomize it to increase cellulation or decrease, or maybe even absent.
That's how I would do it. I'd make it a black and white thing,
Yeah.
And would you mentioned that that's predictable or expected in some cases, because
we'd be surprised if it didn't happen. It suggests that the liver is able to do it.
Because we're comparing it to the appropriate response.
Yeah. So to put it in context, we think in a normal individual and a healthy individual, this is a turn-off switch. So if you get a pneumonia, this happens. And what it does is it happens after the pneumonia has reached its peak. So what it does is it turns off the neutrophils coming into the lung. But what happens, I think, in certain diseases such as COVID, or for example, cystic fibrosis, you get this M0, M1 patterns of alpha-1 because there's continuous stimulation, continuous inflammatory stimulation, which you're not able to clear,
I think it's amazing, because that might actually mean that patients who are actually sick before receiving the transplantation might actually be better.
Exactly.
I mean,
Yeah.
they would be in a better state.
That's
like-
what happened with acute MI.
Yeah.
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 There was a paper in 1979 from our hospital. The physician is now like head of cardio something, but he was just like a resident then. And he measured the incoming patients, alpha-1 and a few others. When they came into the ICU, it's like, and then the outcome. And he really found that if you come in for any reason with higher alpha-1, you have a better prognosis.
Yeah.
With
It
cardiac.
suggests that you're able to respond, you know?
Yeah, that's why I'm not a physician, because I would infect these people
Yeah, exactly. Yeah, yeah.
And it's
yeah.
hard,
before the transplant. So.
and it's actually hard, you know, to differentiate between, let's say, systemic damage, which you can see by alpha-1 because it's an acute phase reactant, rather than actually maintaining, let's say, a good response or a significant response from alpha-1. That's why I think that patients who actually responded with higher levels of alpha-1, they're not necessarily, it's not necessarily a bad sign, right?
It's not.
No, it's must be a good thing, yeah.
But it's how do you say, like revealing. It tags them as already being inside some kind of a stormy.
Exactly. It means that they've seen some sort of a cytokine hit of some sort, I would think.
Exactly, because alpha-1 doesn't go up for any small
No.
reason.
Yeah.
So the hypothesis has been updated.
Yeah.
Because the first time we found that alpha-1 is higher in the poor prognosis,
Yeah, I was surprised.
we're almost close to that.
No, it's a good thing.
Yes.
Okay, so I think what we'll do is I'll actually try to send you what we've come up with up so far, and I would like Oystein to send me the glycosylation patterns, and we'll try to come up with we'll try to incorporate it into the data frame that I have. I'll send it back to you to see if it fits what you've measured. We can actually do that I think it's pretty fast. We can do that. I'm just thinking about trying to incorporate all of the patterns into the functional analysis that I've done, so we can actually see if we find anything unique.
Do you have any kind of a way to name an outcome, like to code it, like to define it?
I think that we'll try to define it like you've said, increased or decreased.
Oh yeah,
Yeah.
Glycosylation or decreased.
Or presence or absence of M0, M1 bond.
Well, we can do with like we do with antibody titers. You can do 1+, 2+, 3+.
That'd be a good way of doing it. Yeah, that'd be a good way of doing it, actually. Yeah.
For like extreme and less
Like
extreme.
increased, decreased, or absent. We can do that, right?
Well, that's minus,
Yeah.
flat, and plus, but you can do 2+ when it's
Yeah,
That's
that's
that,
a
like
good
stuck to
idea.
the tip.
2 plus is
Like
0.
a streamer.
Okay.
Wow.
So I think that's a good way to start, and I think we should also discuss the M-null mutations and to see whether or not they had a plural outcome, because that might be
That'd be really interesting. That'd be really interesting. Yeah.
I
So
think it's very surprising. I was completely shocked that you guys made that find, because I was not really anticipating any, unknown deficient.
One caveat there would be, it could be that their liver is so shot that they're not making alpha-1.
Yeah.
And there could be MMs who have low levels of alpha-1 because their liver is not good enough to produce it,
Yeah. The only one that really stood out, like most of the levels were sort of it's below the cutoff for a normal MM, but the only one that really stood out was a 0.85, which is quite low. But I'll send you every single one with their corresponding alpha. Yeah.
Great.
okay, if we will we be able to understand the file? Is it like Excel? I mean,
Yeah. Certainly, yes, yeah.
like
If
you're
you
gonna
are-
already
well-
code it, hypersilated and on like that. Okay.
We can, I think we can just look and,
Do you remember before they died, the numbers?
yeah. But
So well, for them, like
you know what? I'll send you the file. I guess you actually have it, right? With all the clinical data. So we can add that with a few more columns and move from there.
yeah, but I'm just saying, do the numbers of the 4 that died fit the ones that they found as different?
I can. Do you have the outcomes for these patients? Did they send you?
No, we don't. We were totally blinded on that. We don't know the outcomes for the
Just the
patients.
numbers.
Just the numbers. Yeah, we just had
Want to look at
prefix
them?
like R for Rambam, and then
Yeah.
number.
So the patients who actually died, you can see that already if it's who died early. I'm talking about dying before day 28. That's they're all from Rambam.
Oh, right.
So it's 3, 10, 20, and 22.
Okay, so just off the top there, 20 was one of the people that was suspected as a null.
Wow.
Oh, listen, this
Wow.
is this is a really sad story. This is
Sad.
it's the youngest patient that I had. It's the youngest patient that I had. He was 24, I think, years old, and he had T cell acute lymphoblastic leukemia. I think I'll send you anything. This is
Wow.
this is one of the patients who I had the hardest time with, because we were against the time considering his situation. I think he had a very rapid transplantation matching, and it was really sad. I think that the doctor who was responsible to his therapy would be very much
Relieved,
intrigued
yeah.
by this
Relieved,
this
I think.
revelation.
Relieved. I mean, you think maybe your friend had it.
There was a very a big consortium with all of the hospitals considering his situation. It was a really sad story.
Wow.
This is really interesting.
And it basically, it's not even insufficient function. It's no alpha 1 or something.
He's not an M though. He's an M null.
M null. So I mean, like
He's not a null null.
he's not a null. So I mean, like they look like phenotypically they look like MM, but he is deficient alpha 1. So it's a big query that he could be an M null.
So it's one of two things. It's either he's not producing enough alpha 1, or he's because his liver's not up to it, or he's just
Deficient.
genetically deficient.
Yeah.
You know,
Yeah. Maybe he's I mean, maybe it's not even functional. I mean,
Yeah,
but
that's true too. That's true.
in addition.
Yeah.
Okay.
this is interesting. Tila would appreciate our work, I think.
No, this is really powerful. And you know what's pretty amazing is, was it powered in the beginning from like 200 at least? Like, you power the study way before.
Yeah.
And we knew that those numbers, we could never achieve them in reasonable time. So the study is smaller, and still you have some statistical significance. So it's even more powerful.
Do you guys think that the predisposition of high glycosylation patterns before, I mean, I'm talking about day -7, because we're really focusing on the anti-PR3 activity on day -7 and day 28, like to see what was the change, or even the patients who had more functional alpha-1 antitrypsin before the transplantation had better outcomes. So do you think that these patterns would impact, I would say, the functionality of alpha-1?
Let's see which group got them.
I mean, we're gonna check that. But
Just in case.
I think about what you think. I mean, if you think that would be a reasonable, direction.
Yeah, it's interesting. You see, theoretically, it's a normal physiological response, the glycosylation. But if it's prolonged, it shouldn't be prolonged. If it's prolonged, it suggests that the inflammation is still there, so it's not switching off anything.
Yeah, and there was quite a few of I can't remember the actual number I had in the slide there. Well, I think there's approximately around 23 people who had it, and who had it before transplant, and quite a number that prolonged throughout persistent throughout. Yeah. So
Like day 0.
Yeah,
exactly. So let me just I'll be able to find that number for you.
Yeah.
So it's supposed to be an abrupt, short-lived kind of shutdown.
Yeah, we have done it
authentic.
years ago in community pneumonia, where it goes up for a few days and then comes down again.
Yeah.
And so we might send that on as well. That's a nice one. It's an acute insult. And what's happening is with COVID, it just stayed up because the inflammation was there.
Wow.
And the glycosylation was significantly higher than you'd see in the graft with associated people. They're all M0s.
Yeah.
So they're all at the very top peak of silation.
Like you would consider a very high glycosylation pattern, response.
M0, M1.
What's the
M0
actual liver?
is the highest you're going to get. But you know, it's fine and it's normal if it gets shut off, like in community acquired pneumonia. But if it's persistent, well, you know, that's just abnormal.
And is that all determined in the liver? The exposure of a liver
Yeah, it is.
cell?
Yeah, no,
It's almost all liver.
almost all liver.
So maybe that's why the liver is almost targeted.
Yeah. Yeah.
The liver is very.
You know, it would be also very interesting to see whether or not the prophylactic regimens that being used affect this glycosylation pattern. Like if you think about methotrexate or even mycophenolate mofetil CellCept, they might have a very distinct influence, because what I could actually see, and it's not in this, it's in the supplementary data, that methotrexate actually patients who were treated with methotrexate had higher levels of alpha-1 compared to the mycophenolate patients. So
that's interesting. Yeah.
I think it's kind of obvious, because if you think about it, it has some of hepatotoxicity, but I was thinking that it might resemble even higher levels of damage or more, you know, cell death from methotrexate, which also could induce this appropriate AAT response.
Yeah, and is that methotrexate plus or minus folic acid? I don't.
No. They just receive, I think it's a specific dose. They do not receive any additive. And I think that there is actually a trial on adding, you know, folate to patients, to allogeneic hematopoietic stem cell transplantation patients, and they found that it has no impact.
Okay.
So the benefit of methotrexate is actually the immunosuppressive effect. That's the main goal.
Yeah. Okay. So we'll send you on a few of those papers then.
Yeah.
And
we'll send you
all the data.
We'll send you all the identifiers of all the patients, plus their silation.
And if you get any DNA in those people, we move on that fairly quickly to see if they're truly nulls or not.
Yeah.
And let's go from there.
Well, it could, you know what it could be, that we're not ethically approved for DNA.
What?
Privacy matters. We may have, because remember when we chose to do RNA, we
Yeah, there might be a problem with extracting DNA from these patients.
Unless you just track them.
Maybe I can write a new IRB, you know, a new Helsinki
on existing samples.
On existing
No,
samples.
but they'll have to be alive to sign it. No?
First of all, I'll check if the patient is alive, because then it'd be much easier.
That's always
Yeah.
The second thing
The other way you play it, the other way you play it, if these patients are alive, the question is, it's just a clinical test to see how they're doing.
Exactly, and also, you know, to inform them they may have a genetic mutation.
Yeah, it's just, I'd say it's purely clinically relevant.
Yeah, they're actually eligible to be measured because of this background.
Yeah.
So it's a non-ethical not to test them for the sequence.
I think that after this study, we can say that we're all doctors if we treat that patient accordingly, right?
Yeah, exactly. That's the way to do it.
That young one, can you imagine the younger one if they just measured it before?
Yeah.
Like
it's a really sad story, and this is.
But what if
I'm humbled by this revelation. Yeah. Maybe.
Okay.
So
we're between rockets now, so it's daylight, so we're okay.
Okay, of course, yeah,
of course, yeah.
Dr. Harrison and Professor Guerra, I want to thank you both for allowing me to run this collaboration with you. I was very interested in your work, and I think that this collaboration is really fascinating, because the use of alpha-1 antitrypsin in this modality of allogeneic transplantation is on the verge of, you know, really succeeding. And I think that I hope that this study would emphasize how important the functionality of alpha-1 is, and deciding when's the right time, you know, to intervene is pivotal for these patients.
We're delighted to work with you fellas. We've also had good experience working with Eli in the past, so we're delighted to work with you fellas.
Yeah.
There's tons of stuff to do.
Yeah.
Okay.
So thank you again.
No problem, that's okay. So we'll see you soon then.
Right.
See you an email and then
you.
after. Okay. Bye-bye.
Bye-bye.
מה? אתה יותר מרוצה ממה שחשבת אפילו, נראה לי.
שמע, ממש עצוב לי.